Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Okay, let's unpack this. Welcome back to The Deep Dive, your shortcut to being well-informed. Today, we're diving deep into a subject that's, well, absolutely fundamental for any clinician dealing with abdominal surgery. We're talking about the critical distinctions between direct and indirect inguinal hernias, our mission. To really cut through any lingering ambiguity, sharpen your understanding, and deliver those clear differentiators, the kind you need for decisive action, at the bedside and in the OR.
Exactly. And this isn't just academic detail. It's fascinating because even with all our advanced techniques, a really rock-solid grasp of these anatomical differences still utterly indispensable in daily practice.
Indispensable,
Yeah, it shapes our clinical suspicion, guides the diagnostic approach, and even dictates key parts of the surgical strategy. The foundations, they're just as vital as ever.
That's a powerful point. Now, before we delve any deeper, just a crucial reminder for everyone listening. The insights we're sharing today are for educational reference.
Well,
Always prioritize your local protocols, establish guidelines, and of course, your own clinical judgment in your practice.
absolutely. We're here to enhance knowledge, not replace those essential responsibilities.
Couldn't agree more. Right, with that important note out of the way, let's jump into the fundamental divide. And it starts, like so many things in surgery, with anatomy and embryology. For both types of inguinal hernias, our kind of North Star, the really crucial landmark for differentiation, has got to be the inferior epigastric vessels. You'll see how these vessels basically become our compass throughout this whole discussion.
Indeed they do. So when we think about the indirect inguinal hernia first, its origin story is inherently congenital.
It's congenital, right?
Yeah, this type arises because the processus vaginalis fails to completely close off after testicular descent. It leaves behind this persistent little peritoneal sac. It's a potential weakness there from birth, which means, while we often see it in kids, it can show up at any age, sometimes decades later.
And its pathway is incredibly distinctive, isn't it? The hernia sac doesn't just push through a weak spot. It actually enters the inguinal canal lateral to those inferior epigastric vessels we just mentioned.
That's the key lateral.
From there, it passes through the deep inguinal ring, travels along the whole length of the canal, and because of that longer journey, it often drops right down into the scrotum, or in females, the labium majus.
Exactly.
And crucially, because it follows the cord's path, it gets covered by all three layers of the spermatic cord fascias: internal spermatic, cremastric, external spermatic. It's literally inside the cord structures.
And that embryological route explains the patterns we see. It's the most common type overall, often in younger patients, children. But interestingly, even though it's congenital, things that chronically raise intra-abdominal pressure, like a bad cough or straining, they can definitely push contents into that already open processus vaginalis and make it obvious.
Okay, so that's indirect. Now let's pivot to direct inguinal hernia. This is a totally different situation.
Completely different.
It's fundamentally an acquired condition. We're not talking about some leftover embryological bit here. It's more about a direct weakness, a bulging of the posterior wall of the inguinal canal, specifically the transversalis fascia, right? That classic spot, Hesselbach's triangle.
Hesselbach's triangle. Classic anatomy. It's key for diagnosis and, it's the site of the repair for direct hernias. Its borders are textbook, inferior epigastric vessels laterally, the edge of the rectus muscle medially, and the inguinal ligament down below. Understanding those borders defines exactly where a direct hernia pops out.
So given that location, its pathway is also pretty distinct, right? Instead of following the cord down the canal, the direct hernia just pushes directly forward immediately.
Straight through
That weakened floor of Hesselbach's triangle. So this means it's always medial to the inferior epigastric vessels. And because it's this broad-based bulge coming straight forward, it rarely goes down into the scrotum. And importantly, it's not covered by the internal spermatic fascia.
Right, and its associations fit perfectly with it being acquired. You mostly see this type in older males, usually over 40.
Makes sense.
Yeah, it's often due to just age-related weakening of connective tissue, that transversalis fascia thinning out. Then you add in chronic straining, maybe COPD, constipation, heavy lifting, and you've got the perfect setup for a direct hernia. The real kind of aha moment isn't just memorizing medial or lateral to the vessels. It's realizing this embryological difference creates two fundamentally different processes that dictates demographics, complication risks, and ultimately how we manage it. It's the why behind the what.
Okay, That anatomical blueprint is super clear. Let's translate it to the bedside now. This is where your clinical skills, the history, the physical exam, really bring those differences to life, often giving you the answer right there.
Absolutely. The patient's story often gives you those critical first clues. They might describe, a dragging feeling or an ache in the groin, discomfort that gets worse towards the end of the day or when they strain. And what's often quite telling is that it feels better when they lie down.
And the swelling, of course. That's usually the main complaint. They'll report a lump that pops out, sometimes quite noticeably when they cough or stand up. It usually goes back in, reducible. But a key hint, even just from the history, is that indirect hernias are much more likely to cause swelling that actually goes down into the scrotum. That alone can point you towards indirect.
Good point.
Now, onto the physical exam. This is where our hands really do the work. You need to inspect the patient both lying down and standing up. Look carefully at both groins, any swellings, old scars, asymmetry. Then, critically, get them to cough or do a Valsalva. Watch for that cough impulse, the classic hernia sign.
And for palpation, your key landmark always is the pubic tubercle. Find that first. The canal is just above and medial to it. Then comes that classic technique. Patient standing, you gently invaginate the loose scrotal skin with your index finger.
Gently, yes.
Gently. Follow the spermatic cord upwards till you feel the superficial inguinal ring. It's definitely easier in thinner patients, but you can usually manage it.
Okay, this is where the exam really starts to differentiate. Once your finger's in position at the ring, what are we feeling for when they cough? What tells us if it's direct or indirect?
It really comes down to the vector of that impulse, the direction it comes from. For an indirect hernia, what you feel is quite specific. It's a forceful, sort of expansive impulse hitting the tip of your finger. The very tip. It's coming straight down the canal from that deep ring laterally. Sometimes it's subtle, maybe pushing the side of your finger, but it's coming down. But for direct hernia, the feeling is distinctly different. You get more of a diffuse, bulging impulse that pushes against the pad of your finger.
Ah, the pad.
Because it's coming directly forward through that weak posterior wall, medial to your finger, not down the canal. That tactile difference, tip versus pad, is incredibly diagnostic.
And we can take this even further, right, with the reduction and occlusion test, the deep ring test.
Exactly. First step, if there's a bulge, you gently reduce it, push it back in. Then you formally press over the midpoint of the inguinal ligament, just a bit above the pubic tubercle. That's where the deep ring is located. You're essentially blocking that entrance.
Got it, blocking the deep ring.
Then ask the patient to cough again. And the results here are usually very clear. If the hernia does not reappear, it's highly likely indirect because you've blocked its only path out the deep ring.
Makes sense.
But if the hernia still bulges out, pushing forward medial to where your finger is pressing, then it's almost certainly direct. Your finger is blocking the deep ring, but the direct hernia doesn't care. It bypasses that completely.
Okay.
And just a quick note on auscultation, you should listen over the swelling, especially if you suspect bowel might be in the sac, listening for any bowel sounds. But the real takeaway here, despite all the fancy imaging we have, is that the bedside exam, it still reigns supreme for inguinal hernias.
Really? Still the king?
In many ways, yes. That real-time tactile feedback often gives you the definitive answer faster, more reliably sometimes than waiting for a scan. It guides your immediate management with a confidence imaging alone can't always provide.
Okay, so diagnosis made, usually clinically. What does this distinction mean when we get to the OR for the surgical approach? Because as surgeons, the goal is always pretty straightforward. Reduce the hernia, fix the defect, stop it coming back.
Right. The fundamental goal, direct or indirect, is the same. Get the contents back where they belong, manage the sac appropriately, and then make a strong repair, almost always using mesh these days, to prevent recurrence.
Okay. So let's talk open approach first, like the Lichtenstein repair. The initial steps are pretty standard.
Quite standard, yeah. You make an incision parallel and just above the inguinal ligament. Open the external oblique aponeurosis that exposes the canal and the cord structures. Then you carefully mobilize the spermatic cord, lift it up, usually with a Penrose drain or tape. But the real difference comes in how you handle the hernia sac itself.
Ah, okay. Sac management. Tell us about indirect first.
Right. For an indirect sac, you'll find it located anteromedially within the cord structures. It's actually part of the cord complex, that persistent peritoneal outpouching. You have to meticulously dissect it free from the vas deferens and the vessel's delicate structures, trace it all the way back to its origin at the deep ring. Then you ligate it high up at its neck, often with a transfixion suture if it's big, and then you excise the distal sac. That high ligation is key to getting rid of that patent processus vaginalis and preventing recurrence. You're removing the source.
Removing the source. Got it. Now, what about a direct sac? How's that different?
Very different management reflecting its acquired nature. You'll see it as a broad-based bulge medial to the cord, just pushing through that weakened posterior wall. This sac is usually just bulging peritoneum and maybe some properitoneal fat. Crucially, you typically do not open it.
Don't open it.
Generally, no. Instead, you just invert it, push it back into the properitoneal space. Sometimes you might place a suture or two to flatten it out, placate it, but the main focus isn't excising a distinct sac, it's reinforcing the weak wall it's pushing through.
Okay, that makes sense anatomically. Yeah. So the repair principles then. For indirect, is it just about the mesh, or do you specifically address the deep ring?
Well, the main mesh repair usually covers everything, but yes, for indirect defects, especially if the deep ring is really wide and stretched open, you might consider tightening or reconstructing the ring itself. But mostly the focus is on the overall floor reinforcement. For direct defects, the repair is squarely focused on reinforcing that weak spot, the posterior wall, within Hesselbach's triangle.
Right, and this is where mesh repair, especially the Lichtenstein technique, really shines, isn't it?
Absolutely. You place this sheet of prosthetic mesh over the entire posterior wall, basically creating a new, strong floor. You carefully slit it on the side to make room for the spermatic cord, secure the tails around it. Then you anchor the mesh medially to the pubic tubercle, inferiorly to the inguinal ligament, and up top to the rectus sheath or internal oblique muscle. It creates this really robust reinforcement of the whole myopectoneal orifice, covering potential spots for both direct and indirect weakness, even ones you didn't see clinically.
Very comprehensive. Now, shifting gears quickly to laparoscopy, TAPP or TTP, that posterior view must offer a different perspective.
Oh, it's a fantastic view, almost revelatory sometimes. From behind, looking forward, the anatomy is stunningly clear. An indirect hernia is plain as day. A defect lateral to the inferior epigastric vessels, right where the deep ring is.
Okay.
A direct hernia, equally clear. A defect squarely medial to those same vessels pushing through Hesselbach's triangle. It's like seeing the anatomical diagrams come alive.
Wow.
And the operative principle laparoscopically is a bit different. You develop that properitoneal space, gently pull the sac back, reduce the contents. Then you place a large piece of mesh to cover all the potential hernia spots, direct, indirect, and even the femoral space below. It's a physiology-based repair covering the whole region.
So the mesh covers everything regardless. Does the specific type matter as much for the repair itself then, laparoscopically?
For the mechanics of placing the large mesh may be less critical than in open surgery where you might tailor things slightly. But knowing the type is still incredibly important for understanding the anatomy during dissection, ensuring you've fully reduced the correct sac, and just generally knowing the patient's specific pathology. What's really fascinating is how the operative field, whether you're doing it open or laparoscopically, just constantly reinforces those anatomical distinctions we talked about, that relationship to the inferior epigastric vessels. It truly guides you not just for diagnosis, but for safe and effective sac management too.
So wrapping this up, what does this all really mean for you, the clinician listening? This deep dive really underscores that for doctors, for surgeons, telling direct from indirect isn't just, academic trivia. It's applied anatomy. It's the bedrock of clinical confidence.
Absolutely. And while, yes, modern mesh techniques are fantastic and cover the whole inguinal floor beautifully, that knowledge of the specific hernia type, it's still indispensable. It guides your dissection, ensuring safety. It dictates how you manage the sac, especially that crucial high ligation for indirects. It helps you understand why hernias might recur, and it's vital if, for some reason, you need to do a tissue-based repair without mesh, really getting a firm grasp of that relationship to the inferior epigastric vessels that truly unlocks both accurate diagnosis and informs the most effective repair strategy.
And that's a powerful thought to leave you with. As surgical techniques keep evolving, maybe simplifying parts of the repair, does our deep anatomical understanding become more critical or less? Perhaps it actually lets us innovate and adapt even better when we face those unexpected challenges in the OR. Something to mull over until our next deep dive. And please remember, this information is for reference purposes. Always consult and stick to your local clinical protocols and guidelines in practice. Thanks so much for joining us for this deep dive.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.